everybody. Thanks for coming in. And we're just going to wait a few seconds more, maybe 10 seconds, to allow people who are logging in currently to get themselves into this place. And I hope that wherever you are in Canada, the sun is shining and it's spring. Well, it's fine for Ottawa, but I know that Dr. Wieman and I were talking, it's not necessarily the same everywhere in the country. All right, let's get started. I'm Senator Dr. Stan Kuchar, and this is one of our series on mental health care and primary care. Our first in the series talked about how important it was to have fully integrated mental health care and primary care as the foundation of all health care. Our next talked about human resources in primary care and how to best develop those human resources and models of delivery. And then we had a really interesting session with pharmacy and how pharmacists can expand their roles in primary care. And it is so wonderful to have Dr. Nel Wieman with us today from the other coast, as I say, British Columbia. She was talking about the cherry blossoms. I was so jealous. She is a psychiatrist and the Deputy Chief Medical Officer of the First Nations Health Authority in British Columbia, which is a unique model, and hopefully she'll be able to tell us a little bit about it later on. And Dr. Wieman and I go way, way back, and maybe if she's comfortable, she'll tell you how we first met. Anyhow, I want to focus on access to primary care. We know that mental health care should be delivered in primary care. We need to break the silos down. We need to integrate. We need to have mental health care where people get their health care. And we know that access in primary care has been a huge problem for many Canadians, but it's been even more problematic and more challenging for Indigenous peoples. And the report In Plain Sight, we know, identified some of those concerns. And so maybe that's a good place to start. What about access for Indigenous peoples? What do we have to do differently? What are we doing right? Where should we go from here?
Well, thank you very much, Senator Kuchar, for having me with you on this series. Before I start, I just want to quickly acknowledge the territory on where I'm situated, which is the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh. And yes, it's delightful to be here. As you mentioned, I think we go back something like 25 years. I practiced as a psychiatrist for over 20 years, and now I've been at First Nations Health Authority for 4.5 years. And I say to the listeners, Senator Dr. Kuchar is partly responsible for me because he passed me on my Royal College specialty exams, even though he had a fearsome, intimidating reputation. But as we have worked collaboratively over the last couple of years on a variety of different projects. So it's always a pleasure to team up on something like this. But we're here to talk about, mental health and primary care. And I think one of the biggest issues that we can start talking about is for Indigenous people is access. And access has so many dimensions. It's not just that there are bricks and mortar buildings in communities that are readily available to First Nations, Métis, Inuit people, wherever they live. It's also about having, the providers who are willing to provide service. And because we have so few providers in many cases, appointments for even primary care are, very far in between. And the other issue around access is even if you have a service and plenty of providers in place, are First Nations, Métis, Inuit people going to actually access those services? And one of the reasons why they choose not to in some cases, and we've heard this, for example, during the COVID pandemic, people being really unwilling to come forward and seek help, is because they have a fear or an apprehension about how they are going to be treated. because of how they've been treated in the past, their past experiences of racism, discrimination, underdiagnosis, lack of treatment, etc. So there are a lot of issues around that.
Well, thanks for raising that, and we have to have some uncomfortable conversations if we're going to move towards a reconciliation. And I have had the privilege of working with two of my favorite colleagues, Senator Brian Francis from Prince Edward Island and Senator Dan Christmas from Nova Scotia, who have helped me understand much better this systemic racism that now we were working in fisheries and oceans, but that I know I've seen it within the healthcare system. And that is a huge barrier for Indigenous peoples.
Yeah. So I think, there was, you mentioned, I think earlier, the In Plain Sight report. And because I'm situated here on the West Coast, of course, I'm really familiar with that. Um, and there is not just the full report or the executive summary, there's actually the data report, which is very rich with information. So, for example, it shows in British Columbia, um, Indigenous people have much higher unattachment rates to a primary care provider than the general BC population. So there is that need. But there is also a section that speaks about mental health needs. And because of the history, going way back of colonization and some of the terrible, horrible experiences historically, like the residential schools, the Indian hospitals, the day schools, the 60s scoop. There's a lot of intergenerational trauma and, of course, a lot of contemporary trauma going on in some people's lives. And so mental health needs are really complex. And you and I probably both know as psychiatrists, in the primary care setting, somebody with really complex needs doesn't necessarily kind of align with models of how primary healthcare is delivered, which are based on, very fast appointments, fee for service
Right.
models. Primary care providers aren't necessarily motivated or able really to give that person the time that they need. And then when you think about Indigenous people, having difficulty accessing in the first place or being very reluctant, because of that distrust, you need trust in a therapeutic relationship when you're talking about mental health, especially when you're feeling very vulnerable. Um, that model doesn't really align for that. And so it's really important, I think, to have mental health embedded within primary care so that, people can access it when they're ready to talk, when they want to talk about it, and not feel that they're shut down, after 5 or 10 minutes. Being able to talk about some of those things, I think, is really critical and part of what we call cultural safety.
Right, right. And what I hear you saying, and you correct me if I'm not exactly capturing it, is that the primary care is essential and necessary integration, but the way that it is delivered and how it's made available has to be really cognizant of the needs of the Indigenous peoples that that will access it.
Yeah. Yeah, no, that's it. I mean, people, part of cultural safety is, cultural safety, of course, is an outcome of providing good, primary care, medical services, practicing with cultural humility. But people will go and seek mental health services in the places that they're most comfortable. So for, many First Nations, Métis, and Inuit people, of course, that makes sense that that would be where their primary care provider is as well,
Hmm.
more likely to seek services. And, one of the things we found during the COVID pandemic, when here in British Columbia, when, things started escalating in March or April of 2020, is First Nations Health Authority, where I worked, recognized that need and set up two virtual services, one a primary care service called Virtual Doctor of the Day, and another a psychiatry and addiction medicine specialty service, that were kind of, companions to each other. So someone could see a culturally safe primary care provider, and if they had mental health needs, they could be referred on to either a psychiatrist and or an addiction medicine specialist. And in fact, probably what we didn't want to happen happened in the sense that we reached full capacity, and there is now a waiting list, which we never, that's another barrier for people to seek care, is those waiting lists that people just get tired or don't want to wait for 4, 5, 6 or more months to see, um, you know, either a primary care provider or a specialist. So those have been two success stories of ours during the pandemic, and those will be legacy pieces moving on into the future. They will still be there to provide services because, as Indigenous people, First Nations, Métis, Inuit live in a variety of different settings all over the country, in urban, rural, and remote and isolated settings.
Well, it's encouraging to hear of your work and the First Nations Health Authority's innovation on that part, and that I think can be an example to the rest of the country for sure. And as you think about it, and as you look across Canada, what are some pieces of advice that you would give if you were speaking to a provincial territorial premier and say, look, premier, these are the things that you need to do to ensure that primary health care is respectful of and Indigenous needs and meets those needs? What kind of things would you be telling them?
Boy, those would be long meetings, but I think one of the first things that we always say is we need to close the gap in health disparities and mental health disparities. It's widely known and recognized that the health and mental health status of First Nations, Métis, Inuit people is lower than the general Canadian population, even the most basic indicator like life expectancy. So, we need to close that gap. But that gap has existed for quite a long time. And so I think, we need to look at different models of care, because the other thing to remember when we talk about disparities is that there also is a lot of diversity across the country. So there are places where First Nations communities, for example, are doing really well, and are really strong, are strong in their culture and traditional practices. And we have a lot to learn from those places that are doing well, so that we can translate some of what we know to communities that maybe are struggling or have more challenges. The other thing I think to remember, especially, and this, talking about mental health is not just sort of the absence of mental illness. It is impacted by so many different factors, that we call social determinants of health or cultural determinants of health. There are many, many things that impact upon someone's mental health. And for Indigenous people, our view of mental health and health in general is much more holistic and broad. So, being in balance physically, emotionally, mentally, and spiritually is really important, and is impacted by things like housing, poverty, being able to get an education, having control over health services, for example, self-determination. So there's so many things I would tell that premier, but what I would say is, there are models across this country, not just in British Columbia, that are providing amazing primary care services, inclusive of mental health, that we can learn from, and take some of those key messages or key things that they're doing and try to innovate in other places across the country where the needs are so great as well.
Yeah, I completely agree with you on those points that you're making. There are just a couple that I'd just like to unpack a little bit more. You talked about the diversity of experiences across the country, and absolutely, but also the diversity of challenges across the country, right? Because they are linked. If you're in a community that hasn't got clean water and has a high maternal mortality rate, that's a real problem, and that's going to have major impacts on everything. So part of our focus on improving mental health, which may seem unusual to some people, but I think we're on the same page here, is that we have to really address poverty, we have to address racism, we have to address marginalization, we have to address economic instability, food insecurity. But those are fundamental. You use the phrase social determinants, but those are fundamental to mental health.
Yeah. Yeah, no, I mean, I think, I've heard a lot in the media over the last couple of days or weeks um, about people really struggling because they lack those fundamentals. And, everybody has those needs. And when we have them, it's hard to empathize. This mental health week this week is all about empathizing with other people and trying to see the situations that they're in. And I think despite some of these many challenges that First Nations, Métis, and Inuit people have, and they're definitely challenges, I think one thing that, your listeners, your viewers might be interested to know is, there also is an incredible amount of strength and resilience within First Nations, Métis, and Inuit communities. And that's why I think in primary care, for example, that would be inclusive of mental health services, we would be looking at services that are much more broad, right? So that, for example, are inclusive of both Western medical practices, but also traditional ways of knowing and being on the land, healing, for example. Um, yeah, but you're right. We are, I think, starting to make a difference in some of those fundamental needs. For example, ending boiled water advisories in communities across the country. There's some progress that's being made, but there still are so many other factors that we need to work on, and it's going to be hard, like I said, to close that gap if we don't actually take a look at some of those underlying factors that impact on mental health.
Well, you said it so well. It's been my experience that many people confuse having good mental health with feeling happy or feeling positive today. I feel, I'm happy today. I've got good mental health. Yesterday I was sad because my mother died. I had bad mental health. That's not how mental health works. It really is having the capacities to deal with challenges that life throws us. But if life is impacting negatively on our ability to do that, say through poverty or through marginalization, it's just really hard. So one of the best ways that we can improve mental health of people is to improve their lives, improve their social situations, improve their access to basic necessities.
Yeah, and I think, for Indigenous people, I think, we can't discount these historical experiences that I talked about earlier. I think a common myth that people have is, this sort of, this happened such a long time ago. I'm not sure why this is still an issue, right? And the media actually perpetuates it to a certain extent by only showing black and white pictures, very old pictures of children attending residential schools when the last residential schools closed around 1996, 1998, right when I was finishing my psychiatry training. So it wasn't that long ago. And because of this, these experiences, there is that distrust that I mentioned off the top for all types of kind of organized institutions, right? So the health system, the education system. People are reluctant in some cases to have kids go away to school because of their own experiences that they may have had, or their parents or their grandparents at residential schools. And partly related to what we're talking about here today is, we still have Indigenous physicians, for example, are very much underrepresented amongst Canadian physicians. I think, we don't actually have great numbers. We probably have somewhere 400, 500, 600 Indigenous physicians in the country, still less than 1% of Canada's physicians. And psychiatrists, I think we only have maybe 10 or 15 psychiatrists in the entire country.
Yeah.
And And so that's another area that we can move on and accomplish the aims that you want to achieve, that you're amplifying here through this series about mental health in primary care, is increasing those numbers of Indigenous physicians and other healthcare providers, because we know, for example, from the In Plain Sight report, people feel unsafe when accessing care. But one of the factors that makes people feel, First Nations people, more comfortable is seeing an Indigenous health provider.
Oh, absolutely. Totally. And along that line, if we're thinking about a mental health human resources strategy, a national strategy, if we want to go along that line, and we will be moving there in our discussions, what kind of things need to be done to encourage, support, reach out to, welcome, pull in Indigenous people like yourself? Like, what was it that gave you the impetus to go into this area, this underserviced, challenging, really hugely challenging area? You could have gone to with a gazillion other things to do, So, but what can we do to encourage young people to see this as a career path and help them be successful in that? What are your thoughts on that?
Well, again, there's so much I could say, but I think in the first place, for young people that I've met, and I've heard this from many other Indigenous physicians when they've met young people, is they just don't know about us as Indigenous physicians. Young kids, I used to work in a role model program years ago we spent a week or more in a First Nations community working with grade 4 to grade 8s. And they were like, wow, I didn't know that we could be doctors. I've never met a First Nations doctor before. So I still think, even 25 years after I've graduated from my specialty training, there are still kids across this country that don't realize that they could do it. And, if you can't imagine yourself in a role, then it's pretty hard to see how you're going to get there. One of the major developments I think that's happened over the last year or so has been the creation of what's called the National Consortium for Indigenous Medical Education. And that was, an idea that was kind of founded by 6 Indigenous physicians: Dr. Marcia Anderson, Lisa Richardson, Darlene Kitty, Sarah Funnell, Evan Adams, and myself. And we received funding from Health Canada over the next 3 years. And we have 6 streams of work. And part of our work is, how do we look at recruiting students into medicine, Indigenous and non-Indigenous? How do we ensure that the learning environment is safe, but also comprehensive and covers Indigenous health issues? And then how do we support people after graduation? When I graduated from my training and I worked on the 6 Nations of the Grand River Territory for 8 years, there wasn't a lot of support for me as an early career physician. And working in a First Nations community where there was a lot of trauma, I think I saw something like 1,500 people for multiple episodes of care. When you're practicing kind of solo like that, you experience a lot of trauma. It's very heavy work as a psychiatrist, actually. I think some people, that's another myth that people have, is that working in mental health is sort of somehow easier because we're not cutting people open and stitching them up. But actually listening with empathy and compassion to somebody's story and being able to formulate a treatment plan and establish that relationship is really hard work. So I raise my hands to all mental health professionals across this country, because it is really tough work. So wandering off a little bit, but to say that, in psychiatry, for example, I challenge psychiatrists all the time about why psychiatry doesn't seem to be an attractive specialist for Indigenous medical school graduates. Why aren't we making it an attractive specialty? And, I don't know the reason why. That's not my question to answer, but I think we have a lot of work to do. around encouraging people. And when you think about it, mental health care, I mean, my background was completely different. I had a background in kinesiology and biomechanics. How did I end up in psychiatry? I ended up in psychiatry because I had a wonderful, wonderful preceptor, Dr. Nick Cates, and I started to learn about the art of medicine. And I think it kind of resonated with the oral tradition that Indigenous people have, that I loved hearing people's stories. And so I think, when we're talking about this during Mental Health Week, that I think is important even for non-Indigenous mental health providers. It's about listening to that story and trying to figure out, what could be most helpful for someone. And if that includes supportive housing and not just an antidepressant, then that person is going to be better served.
Oh, I completely agree with you. I mean, there's no pill for poverty. I mean, and it's just, and there's no psychotherapy. If you lose your job and you're demoralized, you don't need cognitive behavioral therapy. You need a job. I mean, it's just, sometimes it just annoys me to no end that people medicalize normal life experience and without realizing that we have to change the structure and capacity of society to be generous and compassionate to people. It just, well, sorry, I didn't mean to go on a bit of a rant.
Great.
So thank you for affirming that. You work in a First Nations health authority. Now that's sort of unique. As you're thinking about it, what kind of messages, lessons can we learn from that particular model?
Well, I was so honored to kind of, in some ways, leave my clinical practice behind and move out to the West Coast to work for First Nations Health Authority. I was so excited to be working at the public and population health level. But you're right, First Nations Health Authorities was the only first health authority of its kind in Canada where we work on behalf of all BC First Nations, meaning we are accountable to all BC chiefs and leaders across this province. So it's a bit of a different twist, but that's an incredible responsibility to have. And we are engaged sort of on what we call a wellness journey rather than just being, delivering either health programs or, that very Western, narrowly defined view of what is health and what isn't. So we take that wellness approach, and it's, again, like very broad and holistic. The other thing I think that makes us a little bit different is, this takes into account self-determination of BC First Nations communities. We listen to the direction and advice and guidance of the chiefs in kind of how we go about our work and the kind of work that we get involved in. So it's a really, for me, coming from the Western medical system, I worked at the Center for Addiction and Mental Health before I came out here. It's a little bit of a different shift in thinking and how we work in partnership. And of course, we engage, our federal, provincial, regional health authority partners in the work that we do. But, I have to say, I'm challenged every day in my work. No day is the same. But I felt for me at this point in my career, it was the place where I could make the most impact and take my clinical experience, my research, my administrative experience, and bring it all together in one place and work, along with BC health leadership to improve the health and wellness of First Nations here in this province.
So that's a model that some provinces and territories could look towards as they're thinking about how to do better in their healthcare delivery. Then that's what I hear you say.
Yeah, and just briefly, I'll say, you can check out the First Nations Health Authority website. It has a much longer version of how this came to be. And much of it was achieved before I came to work for First Nations Health Authority. So it's an interesting story. And as you say, an example, I think, in similar ways in different places across the country.
Well, I was just looked at the time. I can't believe our time's over. So it's
Oh,
gone. Well, Dr. Wyman and now I'm Stan. We talk to each other. It's been just a delight having you, and thank you for your leadership and for your trailblazing, and for your advocacy and having conversations that we need to have. And we're going to have a lot of talks in the future, you and I, because I think that you're onto some things that we need to do, and I'm going to do my best to help nudge so that you'll be successful. So thanks so much for taking the time and out of your really busy day and doing this. Really appreciate it.
well, thank you as well. I raise my hands to you for being inclusive and having this topic as part of the series. So be well.
All right. You too. Take care
Okay.
now.